face. It can even go up to the jaw and even arms.
Sa mga buntis kaya, kakaroon ng pimples.
Oo nga, meron din. Pinsan ko rin daw.
So, ang daming pimples na lumalabas. Ba't kaya?
Malaman natin. Tatanong ko sa kanya.
Oo,
Sige nga. At saka pwede ba gamot?
Is more than half of the face involved. Increasing the number of lesions, both the basals. So take note that even the trunk can be involved. Okay, the chest and the back, and that can be part of acne, truncal acne. These are some of the sequelae or some of the small, they're narrow, they're kind of thin, and it looks like they've been stabbed by an ice pick. On the scene,
Grabe sa stab ba yan? Ice pick. Ice pick? Stab. Mukha daw in-stab ng ice pick.
Patay.
right? On the chest, we can
Dito.
hypertrophic small scars.
Ito malupit yung nasa dibdib. Parang kala mo lintana dumikit.
Ayan, no, sa akin, no.
Parang chicken
Hindi na. Kaya pinisa-pisa ko nga. Hindi nga, pinampisa ko nga eh.
Sige nga. Bad ko.
Ayan, no.
Lagi ba kasi shampoo yan?
Pati sa likod ko. Oo.
Oo nga. Baka maano yung estrogen.
Saka Makati.
Ay, iba na yan. Tang ina ha.
Tanongin na needed mamaya.
Binipisa ko nga sa, di ba yung dito ko sa tiyan. Kasi dito ko sa likod.
Now, during the which is where the mask is called up, we have to consider mask near acne mechanica, and we have to talk about, changing the mask to
Acne mechanica.
the surgical mask.
Paano kaya yan matanggal, no?
Increase temperature and
Baka
occlusion,
pwede sa
causing
buntis.
fungus and bacteria.
Ano kaya
Hoy, ang tawag pala sa mass acne is acne mechanica.
Now, when we see kind of a U shape along the jawline and the chin, even on the neck, that's usually hormonal acne. And we'll talk a little bit about
Hormonal acne.
Hormonal? Kapag sa buntis?
later.
Ano yung natural lang yun dahil hindi nakalabas yung dumi?
See here from the American Academy of Dermatology, depends
Kasi walang regla.
on the papules, pustules, and nodules.
Kasi pag natapos ako
This classification down here is a little
nawawala
bit
na
more,
din naman siya eh.
based on numbers, but I think it's
Kasi wala siyempre
for
Makati,
clinical
diba?
practice. So anyway, we talked about how to grade severity. I personally like to use the sleet grading. It's an old grading system, but depending
May
on how
classmate
severe
ako
the
ganyan dati yung ano niya.
patients, they kind of look in the
Ganyan
mirror
eh.
and then they
Yung
grade
sobrang
themselves.
mapupula na
Below the
dikit-dikit.
grade of
Hindi,
4 to
dikit-dikit
5
na pula sa
generally is
mukha.
amenable to topical treatments. Okay? But anything above 4, 5, and so on would usually require systemic therapy. Same thing for truncal acne.
Pati sa
It
likod.
also has a leads grading system, so we have to also keep that in mind. So let's talk briefly about acne pathogenesis. So there are 4 reasons why we have acne. One is really oil, okay, sebaceous glands and lobules and hormones. So because during adolescence, the kids usually have the onset of estrogen, progesterone, testosterone, the hormonal activation, and it really triggers these androgens trigger the sebaceous lobule to have more sebum secretion. Not only that, they also tend to clog the opening of the hair follicles. Okay, so we call hyperkeratosis. So what happens is this hair follicle becomes a sac of oil. Okay, becomes a sac of oil, accumulates with keratin, and there can be a lot of bacteria growing in this sac. Okay, which is Cutibacterium acnes. It can be called Cutibacterium acnes. And sometimes when this hair follicle explodes, when it becomes so huge, it explodes, and there's a lot of inflammation. Okay. So for reasons, it's oil, it's the clogging of the pores, it's the Cutibacterium acnes, and it's also the inflammation. So those are the 4 targets for acne. When we look at the different things that are out there for acne, and this is an old study, evidence-based dermatology, done in 2008, looking at all the studies, we can see that the different kinds of medication have different roles to play. Okay, so benzoyl peroxide is good for keratinization. It's also good for it's a good antibacterial. It also helps remove inflammation. For tretinoin and the other retinoids, it's good to remove the clots from the surface. It can also have a little bit of antibiotic and anti-inflammatory use. For clindamycin and other topical antibiotics, these usually just target Cutibacterium acnes. Now, for the anti-androgens like spironolactone or the oral contraceptive pills, these usually affect the sex-binding hormone globulins, and therefore it affects sebum secretion. There are so many things on the market, right? Like azelaic acid, niacinamide. Actually, our patients are really smart. No, they know how to treat themselves with alpha hydroxy acids, salicylic acid. So they're getting very, very savvy about it. So we also have to understand how to use these medications and why to use it. So for azelaic acid, it's good for follicular keratinization. It also has some anti-Cutibacterium effect and also anti-inflammatory effect. It also is a very nice medication for hyperpigmentation. For the oral tetracycline class antibiotics, Cutibacterium acne is also anti-inflammatory. For erythromycin, again, generally topical antibiotics have fallen out of favor because of the spread of antimicrobial resistance, so we have to be careful about using it. And isotretinoin, which is a vitamin A derivative, which is the most effective, especially for severe types of acne. Targets sebum secretions by causing a permanent shrinkage of the oil glands. It removes the hyperkeratinization. The bacteria and fungus, they don't have any oil to eat, so they kind of die off. And the inflammation also gets addressed. So let's start with skin cleansers. Generally, if we don't recommend beads or any kind of exfoliating cleansers, just use really mild soap, okay? And then this synthetic detergents, which are not soaps, which have a balanced pH, are also recommended. So these are derivatives of vitamin A. They have nuclear effects and target RAR and RXR. They have effects on cell proliferation and differentiation, as well as keratinization and inflammation. And so these bind basically to the trans-retinoic acid and cis-retinoic and leads to heterodimer activation. And it promotes the DNA activation and the transcription of the genes. Okay, so it promotes transcription for differentiation of the skin, for apoptosis, and also immune modulation. So it really works at the nuclear level. So what are topical retinoids? Okay, you've heard of things like tretinoin. You've heard of things like adapalene. Okay, you've heard of things like tazarotene, and there's a newer one called trifarotene. Okay, these are all retinoids that are available. So for the oral kinds, isotretinoin is available. Metretinate and acitretin are no longer available on the Philippine market. So early comedogenic acne has follicular obstruction due to slugging, and so topical retinoids can be used both in inflammatory, in conjunction that you use adapalene as a topical retinoid is probably the least irritating than the other retinoids, which is why in some countries it's even sold over the counter. Okay. So combination of this comparison between topical combination of adapalene with either benzoyl peroxide or adapalene with clindamycin. And you can see that the reduction in acne lesions was more significant in the combination therapy than just plain adapalene therapy. And so when you're addressing mild acne, the combination regimens, fixed combination are very effective. So locally, we have the adapalene benzoyl combination. There's also the adapalene clindamycin combination, the benzoyl peroxide and clindamycin combination. We'll talk about that later. Okay. So in general, retinoids are very effective first line for acne. However, when you use the combination of the retinoid with antimicrobial agent, it is very efficacious and actually shows superior efficacy in this fixed dose combination. Here's an example of a tretinoin clindamycin study done. You can see before and after 3 months. And here another study showing the combination of benzoyl peroxide and adapalene, which is blue. The green is plain adapalene, the yellow is plain benzoyl peroxide, and the other one is vehicle. So you can see the response rate for the combination therapy adapalene benzoyl peroxide is significantly higher compared to the other ones alone. Okay, again here another study using clindamycin and adapalene, which is the blue line with the diamonds. You can see the value at week 12, the drop in the lesion counts, okay, of acne, compared to just plain clindamycin alone or just plain adapalene alone. Okay, so these combination therapies are very effective, and as well, once you reach maintenance therapy, our retinoid therapy alone, very effective to target microcomedones, which may not be sticky under the skin, as well as visible lesions. So we do recommend that how you should use this retinoid is put a pea-sized amount on your finger, kind of dot it on your whole face. I call it, and then just gently spread it on the whole face. Avoid the upper and lower eyelids, the corners of the eyes, nose, and mouth, because those tend to kind of peel and burn a little bit if the retinoid gets spot therapy. So this is the reason why we don't do spot therapy with retinoid. You must treat the whole face. Okay? So that's for maintenance therapy. And this is so when you stop the
Ano ko yung
retinoid,
ano,
once the patient gets better, they tend to rebound. And this is why it's
nabigla ako.
Yun na yun.
Nakalive na.
Yun na yun.
Tahimik lang ako.
Hindi sa dapat naglalay.
Mas maganda din yung salita. Nandito ko eh. Tulog ako eh.
Ano kaya tulog ako tapos bigla akong mag-exam. Bagsak pa si Lawson. Wala natutunan sa seminar. Kasi may post-test daw eh. Hindi, yung isa yung natanang ko lang post-test eh. Ito meron lang. Parang evaluation lang.
Pero wala naman pumabagsak ng sensitivity sa
has similar activity to antibiotics against inflammatory lesions, and the combination lesions are more effective than antibiotics alone. So here you can see on the
Clinda.
before and after.
Clindamycin ngayon.
2.5
Diba dati pa nung yan na talaga
monotherapy alone. Alright, as we said before. Now in the US and in other countries they have topical napsol, family, 5% formulation of poisoning about it's quite effective, and it makes it very regulating to keep toxins and free radicals. So very effective. Salicylic acid, medications, beta hydroxy acid, and exfoliate and chemical irritants. So the 2% more effective in reducing all lesion size to acid as well. So you still can use salicylic acid, but just be careful with it being quite irritating to some people. We already talked about azelaic acid. We said that it increases keratinocyte keratolysis. Okay, so it improves that. It also has antibacterial effects. It also has anti-inflammatory effects. So that the ones was equivalent or as effective as retinoid, benzoyl peroxide, and oral cycles. So, antibiotic.
Ngayon, M.
Long distance 088. Parang may lamok. Oh my God.
So for oral antibiotics, for a head-to-head study, and just consistent improvement in about 70 to 90% of individuals involved. So for moderate to severe acne, recommended prescribed. So more effective against inflammatory lesions than non-inflammatory lesions. So we suggest that you add a combination of topical retinoid with benzoyl peroxide to reduce antimicrobial resistance. Now, when you're considering hormonal issues in women, you must always consider in patients with amenorrhea, irregular menstrual cycles, hirsutism, obesity, and severe recalcitrant acne, poison nickel syndrome. This is due to an androgen excess state. So work with an OB-GYN for this, and I do recommend always working with a PDS board certified dermatologist if you're having issues with your acne issues. So indications for hormonal treatment for acne, it consideration for the patient if they want
Hello ma'am, good afternoon. Ma'am, si Hector Labete po ito. Ma'am, ask ko lang po kasi may na-receive kasi akong notification sa IntelliCare. Yung sa, wait ha, yung sa hospital allowance ng anak ko. Yeah, approved na ma'am. Ano yung next? So mag-email na lang po kayo?
Yes, antayin nyo na lang yung email ng clinic, ma'am, kung may send.
Okay ma'am. Kasi may nakalagay kasi dito, in
31
compliance to regulatory, you are still required to
pills
meet
reduce
your
acne
copy
lesion inflammation
Ah,
of your
some patients
Wala na to?
or
Then,
have
pag
results
pag
from
nag-request na mag-submit ka ng
acne.
mga documents,
Drospirenone, COC appear to be more effective than norgestimate or norgestrol
Pag ganito?
acetate,
Yes,
but less effective than
Oh, ganun ba? Hindi
acetate.
ba ang
You have these
nag-submit na nung
combination of
IntelliCare na
pills
mismo?
also locally on the market.
ganun
Just
po,
make
ma'am,
sure
di ba
to always
hospital
talk to your
allowance po
patient
yan?
about
Oo.
smoking,
Ganun po, pag
breast
nag-request
uterine
kasi ng
cancer,
endorsement, ma'am,
family
kasi
history,
sa
and so
kanila
on,
din
and
natin forward
history
yung
of
documents na
clotting.
nire-request ninyo.
So for oral isotretinoin, this is the best treatment
So actually,
for
hindi ako
severe
nag-request
treatment-resistant
noon. Parang
acne.
automatic naman po kasi
It's
yung
frequently
medical
treated with oral isotretinoin.
hospital
It can
allowance pag
decrease
nag-ano,
sebum
di ba?
production,
So,
Yes,
mas
ma'am.
parang sa IntelliCare lang yung
and
tubig
it also
noon.
improves
Hindi naman
keratinization,
kami
it
ang
removes
nagtubig.
inflammation,
Pero po,
and
ma'am, pag
the
nag-request
Bicarbosperum and
pag
Helicobacterium acnes actually also decrease because it has significant effects against these organisms. Okay, so the efficacy of systemic isotretinoin for severe cystic acne
So,
is very, very
pag
well
sila nag-require,
So these
ipadala
are
pa rin
5 hours
namin yan
Yes,
sa inyo.
ma'am.
isotretinoin versus placebo. In all cases, isotretinoin at 0.5
Okay,
milligram
sige
per
ma'am.
kilo
Okay po.
sorry,
Thank you.
yeah, was found to be
Okay.
more effective therapy than any of its comparators. So anywhere from 0.1 milligram per kilogram to 2 milligram per kilogram total dose. All of these doses resulted in a significantly decreased number of lesions. It will address both facial and even truncal acne. So oral isotretinoin should be reserved for severe treatment-resistant acne due to potentially serious adverse side effects, including teratogenicity. I want to warn our audience that some of these medications are available on Shopee, on Lazada, and we don't know where they're from. They're not FDA approved. This is completely illegal sale of medications, and I do want everyone to be an advocate for isotretinoin because this medication is too good to be banned on the market because of irresponsible use by lay people and people who are giving it or to their friends. So look up the severe side effects that can happen with isotretinoin teratogenicity. If a patient is taking isotretinoin and gets pregnant, the baby will have severe great heart lung deformities, chylitis, pruritus, dryness, conjunctivitis, hair fall, musculoskeletal aches, alopecia, fatigue, corneal opacities, disc disease, and in patients with diagnosed depression and suicide, it is very dangerous to give isotretinoin because it can, although it has been debunked that it causes suicide and depression, it may aggravate and trigger. Therefore, you need to work with your psychiatrist if the patient has been diagnosed with any mental health issues. So, lots of side effects for this medication. I do warn people to work with your PDS board certified dermatologist to give isotretinoin. It should not be given left and right. It is a significant medication, very effective in the right hands, but can be dangerous in the wrong hands. So just briefly before we end, let's just talk about neonatal and pediatric acne. So when we talk about neonatal, it's from birth to 6 weeks, infantile 6 weeks to 1 year, mid-childhood 1 year to 7 years, pre-adolescent 7 to 12 years, and adolescent 12 to 19, and then post-adolescent or adult acne above the age of 25 years. So you can see here, little baby, this is actually Cindy's field. I dare not step on her territory, but let's just go through it briefly, okay? Infants with facial acne, mid-childhood acne, pre-adolescent acne, adolescent, and adolescent acne. So in the neonatal stage, we know that this is due to the hormones that are just circulating in the baby. From the maternal side, it is self-limited and benign. Nothing needs to be done. It happens in about 20% of neonates, and so we just leave that alone. However, when you diagnose acne between the ages of 1 to 12 years old, this is mid-childhood to pre-adolescent acne, you might want to consider seeing a pediatrician or a pediatric dermatologist to rule out endocrinologic disease, any tumor or gonadal pathology, especially if it's severe. And if it's affecting the child with regards to mental health, you might want to refer to a psychiatrist and a pediatric dermatologist. Now, in the age of 12 to 19, after menarche, it's quite normal. But also watch out for severe mental health conditions. So here's some examples of comedonal acne and kind of more severe inflammatory acne, which is more common in adolescent types. There are many differentials. For both younger pediatric acne and adolescent acne, so keep these in mind. And there's a very intense algorithm. You can email me. I'd be happy to send you the journals for this. For the pediatric acne, there's an algorithm here, which we don't have time to go through. But as I said, work with your pediatrician and your pediatric dermatologist for this if you're dealing with pediatric acne. So for the mild pediatric acne, first line, again, benzoyl peroxide or topical retinoid, or you can go straight ahead to the topical combination therapy of benzoyl peroxide with an antibiotic or a retinoid with benzoyl peroxide, okay? And then if there's an adequate response, you can shift or change or think about combination therapies. For the moderate pediatric acne, you can start with a combination therapy of retinoid with benzoyl peroxide, or consider oral antibiotics. Now, you have to be careful with your tetracycline antibiotics because remember, before the age of 12, it can affect bone and teeth with some staining and effects on the joints as well. So I do recommend that you work with your pediatrician, pediatric dermatologist to, if the acne is not responsive to topical treatment. And then for severe pediatric acne, again, first line is combination therapy with or without an antibiotic, oral antibiotic, and topical retinoids. Okay. For adolescents, it's kind of the same. Topical retinoids or benzoyl peroxide or both in a combination therapy. If it's moderate acne, you start off with combination therapy, then you might want to consider either oral antibiotic with it. And if it's severe, you start off with oral antibiotic with a combination therapy. And then if it doesn't work in about 3 months, you might want to consider oral isotretinoin. You can see that the level of evidence and strength of recommendations for most of the medications that we talked about are level A and B, and strength A and B, and level 1 to 2. So briefly about post-adolescent acne, this happens after 20 years of age in about 20 to 40% of adults. Usually in the last few decades, we've seen acne occurring in people from 20 to 26 years. However, in 2001, they saw that this was increasing to the age of 40. So about 41% of women aged 25 to 40 was suffering from this post-adolescent or adult acne. Okay, with a peak of about 45% of women between the age of 21 to 30 years old. So this is called persistent acne, persistent or late onset, and usually there's kind of this inflammatory form on the U. Remember, this kind of jawline U-shaped acne is hormonal. And let's look at the triggers, okay? So this is very important. I want to talk to you about all of it. In this post-adolescent acne, the most common trigger was smoking. So when you have patients with post-adolescent acne, ask if they smoke. Because smoking is just incredibly pro-inflammatory. And let's talk about some of the triggers. It is appropriate for all levels of acne that we talk about these triggers now. Smoking, very pro-inflammatory, very bad for the gut. It causes a lot of gut leakiness. Personal history of acne in adolescents for these older women. Family history of acne, no previous pregnancies, insufficient sleep. So we see a lot of our kids and older people now sleeping 3 to 4 hours a day. I do recommend that everyone sleep 7 to 8 hours a day to prevent this acne, okay? Because it's very pro-inflammatory and they're not able to kind of manage their acne if they're not sleeping enough. So talk to your patients about this. Office work, I don't know why that's a trigger for these adult patients with acne. Hirsutism, of course, you have to worry about polycystic ovarian system or some kind of hormonal issues. Work with their OB-gynecologist with this. Higher levels of psychological stress, right? I used to think that stress was mumbo jumbo in acne, but actually you'll find that stress as a trigger is huge because it activates cortisol releasing hormone and it triggers this oiliness, okay, this lipogenesis of the sebocytes. So we have to talk to them about that. And we also talked about sugar, dairy, and high glycemic food. In the past, I didn't believe in food as a problem for acne, but nowadays there's so many studies coming out talking about milk, whey protein, so dairy in general, sugar, high glycemic foods, a lot of fast foods and junk food, even cup noodles and junk food and Lay's, whatever we love to eat. Those are the triggers for acne, and so we do have to kind of be careful and avoid these. Instead, you have to encourage your patients to eat a lot of vegetables, fruit, and fish. So in general, a Mediterranean diet, a low glycemic diet, and avoiding sugar and dairy is very important in our patients at all levels. This is the summary recommendation from the Southeast Asian Acne Alliance study. there was a Filipino dermatologist in the study, and therefore I do recommend that this is very appropriate for us. So in mild acne, topical retinoids, topical benzoyl peroxide, or a combination of both, or retinoid with topical antibiotics, okay, as first line. For the moderate, you start with oral antibiotics, any of them, with topical retinoids plus minus the benzoyl peroxide. And then for severe, they do recommend oral isotretinoin after a failed 6 to 8 week trial of oral antibiotics in combination with the topical retinoids and benzoyl peroxide. Okay, so again, just briefly running through this. Again, I would be happy if you just email me. I will send you the protocols and the journals so that you can refer to it for your practice. Um, um, it, kind of simple, very severe acne. Is your risk of acne scarring? So here on the left side is low risk for scarring. On the right side, high risk for scarring. One of the reasons why you should refer to a PDS board certified dermatologist soonest, even for young kids, is because we know how to manage at all ages, and we want to avoid scarring, right? Because this is not just physical scarring, we're talking about psychological and emotional scarring for our patients. And scarring is very difficult to treat. It's actually more difficult to treat than just doing early intervention therapy for acne. So it says here, if you have early acne-induced scars and have acne, you might be at risk for developing more scars. So these were some of the questions. What is your worst acne? Does your parents simply have acne? How long have you had acne? And do you pick or squeeze your acne spots? Please do not pick or squeeze your acne spots. It is not good. Even though it's very popular on IG, people squeezing out their own acne pimples, so they call it very satisfying. Please do not recommend this to your patients, and don't do it yourselves, okay? Because we'll have to deal with the different kinds of scars: ice pick scars, rolling scars, box scars, keloids, and hypertrophic scars. And of course, the post-inflammatory hyperpigmentation. As brown people, we do have a lot of issues with hyperpigmentation, and therefore a lot of the medications that we talked about today, like retinoids, like azelaic acid, alpha hydroxy, and salicylic acid, are very effective for the hyperpigmentation as well. Don't forget sunscreen. One of the most important, an SPF 50 or higher in the appropriate levels would be effective for this. Okay, so thank you very much for your kind attention. I'm sorry I ran a bit long, but open for your questions. Thank you very much.
Wow, thank you so much, Jack. As for that very comprehensive, very insightful talk with lots and lots of learning points, and very sure that our audience would also agree that acne is just not a simple disease, and that management should really be focused on medical management. It should also be individualized. There's no one size fits all for our patients, and it's really important to seek consult with a board certified dermatologist. No? So at this point, we'd like to thank our sponsor, just very briefly, a very generous batchmate who wants to remain anonymous. Thank you so much for supporting our webinar. So again, we encourage our audience to type in and actively participate in our open forum. We actually have a number of questions already, Jack, in the box.
Sure.
So for our members in the Zoom room, you can actually type it in the Q&A box. For those in the FB live and YouTube Manila live stream, you can actually put your questions in the comment sections. Okay, so I think it's very important to start with the terminologies first, Jazz. There are a few questions about proper terms, like what is the difference between acne and pimple, and what does it mean to have actually acne-prone skin?
Yeah. So pimples is kind of like just the general term, the lay term for acne. So
Right.
it's kind of encompassing all the different types of lesions, right? So pimples, it's acceptable. Acne in a more medical sense, I think it encompasses all of that. So acne-prone skin, I think you're talking about maybe oily skin or super sebaceous skin, skin that is kind of very oily. I think those are kind of the acne-prone skin.
That's right. So oily skin with lots of those.
How about you, Sid? What do you think?
I agree. I totally agree with you. So there are some acne,
That's
pimple.
right.
We usually use them interchangeably when we're explaining to patients, no? But we really need to, like you mentioned, we have to classify them as to having mild, moderate, severe, and the inflammatory versus non-inflammatory. So I think there are also a lot of questions about misconceptions about acne, particularly with regards to triggers, and you adequately discussed this in your slides. So there are questions about eating chocolate as triggers, and whether it's important to have a specific diet for acne patients. Yeah.
Yeah. So since people hate to be on a diet, right? We hate to give diets, but in general, if they're
Right.
talking about treating their acne and avoiding flares, I do say sugar and dairy. Especially like a lot of people love milk tea. It's a combination of both sugar and dairy. So if you're gonna go to milk tea place, get just the tea, no milk, and then put a sugar substitute or no sugar. You can have your milk tea, but without the milk and without the sugar. Chocolates, because it is both dairy and sugar, can
Right.
trigger some people, since not everyone. And the reason for this is because it kind of works through what they call the mTORC pathway. There are some pro-inflammatory pathways that are sensitive to the whey. It's the leucine in the protein. Like even red meats can trigger that pathway. And so if you are sensitive to that, especially in acne, then just avoid it. Challenge yourself to do an 8-week test. So 2 months, no sugar, no dairy, see how your skin is. Then after 2 months, eat as much sugar and dairy and junk food as you want and see what happens. So let's see. Let's just challenge and then see what happens and see if you're
That's
sensitive.
right. Yeah, I agree totally. No, before we didn't think the diet really played a very big role in terms of acne, but with the recent studies that have been coming out, we now have more updates now with regards to the triggers in terms of food. So there's also a question here about the role of azelaic acid in a patient taking isotretinoin. I think you also mentioned this. Is it safe to use azelaic acid for patients undergoing acne Trex treatment or isotretinoin for that matter?
Yeah, it's safe. It's safe. Except I would just recommend when you're taking isotretinoin, your skin will get dry and kind of sensitive and peeling. So everything that's an acid will be a bit irritating for your face. So retinoin is retinoic acid, salicylic acid, alpha hydroxy acid, azelaic acid. Anything that says acid will be irritating for your face. So just be careful. Once you start to feel stinging, burning, just stop it. Talk to your dermatologist and see if you can just, stop it, or if you need another medication.
Yeah, I'm actually glad that you brought up that issue about selling of medications online. Yeah, it's a really good time to warn our patients and hopefully that they should not be, buying their medications online and to seek consult first before they start any medication. So there's also a question here. I think it's more of a case, no? A patient who is actually, what can you suggest for preteens starting to have acne with mother with PCOS or PCOS? And the teen is high risk for PCOS as well. Do you advise hormonal pills at an early age?
No, I don't. So I always work with an OB-GYN. I always refer. If I suggest something, I'll refer to the pediatrician. If it let them sort out the hormonal issues, I can do some hormonal tests initially to go for retinoids. But if it's like a child like maybe 12 or so, you can start with maybe adapalene. It's okay. The mild retinoids might be okay at a certain age. I don't understand how early do you start on retinoids for kids?
Are you talking about topical retinoids or oral retinoids?
Yeah, it's just topical retinoids. I would never give oral retinoids at a baby.
Yes. So for topical retinoids, it depends on the patient. So usually you have your comedonal acne coming during your pre-adolescent stage. So for those, we can give our second and third generation retinoids like your adapalene that would be less irritating. We can give them at I think 7 to 8 years old when they start getting all these, pre-adolescent acne. But we also need to be careful because we need to advise them as to what to actually, expect, right? Like you mentioned, you can get retinoid dermatitis, you can get, some bit of peeling and scaling. So we really need to be able to talk to our patients and, discuss our treatment plan with them, right? So yeah, I think it's very important that we know what the population that we're dealing with, because not all patients with acne would be treated the same way, right? Yeah. So there are also a lot of questions here about post-acne scarring and pigmentation. So is there an effective way to manage your scarring and pigmentation? Yeah.
Right. Yeah, so to see your PDS board certified dermatologist to deal with the scars, no? Because some people refer to pigmentation as scars. Some people refer to the patulubog as scars, which is the atrophic scars. And then there's also the bumpy scars. So there are broad, categories of treatment for these kinds of scars. It can be procedural, right? So you can do maybe subcision, fillers, whatever. There's so many things that can be done. Fractionated resurfacing. For scars, I do suggest you see a PDS board certified dermatologist for either the atrophic or the hypertrophic scars. For the pigmentation, we already talked about sunscreen. We talked about some of the things that are already available on the market for like the retinoids, like the alpha hydroxy acids and things like that. There's even niacinamide, which is available over the counter, which is good both for acne and also for the pigmentation. So there's a bunch of different things that you can use. There's so many things on the market right now.
Yeah. So speaking of sunscreen, there's a question from our FB live portion. What is a good sunscreen for patients with acne-prone skin, especially with the recent issue about global warming? I'm not exactly sure what this was, but they're asking about a good a good sunscreen for acne-prone skin. Yeah.
Okay, so try to find an SPF 50 sunscreen if you're going outdoors. If you're indoors, maybe 30 is okay. But if you're acne prone, if you're very oily, you want to go for kind of a liquid or a gel sunscreen. Okay? Now, if you kind of have dry skin, you want to go for more of a creamy type or of a lotion type sunscreen. I don't want to recommend any brands, Just go to your local drugstore. You'll see a lot of sunscreens there. And try to find something that is fragrance free, that is hypoallergenic, that has SPF 50 and above, that has broad spectrum, which means it protects both against UVB